I guess we'll find out when we review it.
Okay, so starting off, stress test. What is a stress test, and why do we want to stress the body out?
The stress test, doesn't that measure your heart function?
Yes. So we want to stress the heart to try to see how the heart reacts and how it functions during periods of like activity, like intermittent periods of activity. So we can either stress the heart by having them go in like on a treadmill or on an elliptical bike and attached to the monitor, or we can give them medication to stress the heart and make it beat faster and harder and monitor their ejection fraction that way. Okay. So before we do a stress test, what do we need to identify with regarding to the patient? What is like some things that we would do pre-operatively, like prior to the procedure?
Sorry, say that. What we would educate them before the procedure?
Yes.
Would you say like no caffeine?
Yes, that's true. No caffeine. What about like assessing their medications?
Yeah, like heart meds that they're taking?
Mm-hmm. Do we want them to stop it or to continue taking their heart meds?
I would take. I would take it, but it can also be like
We
stop.
we would advise them to hold off on it because we want to see like without any assistance from medication how their heart is performing, right? So we would advise them for the most part to hold off on like heart medications unless they like well, this depends on the certain case, but typically we would ask for them to hold that morning dose prior to the procedure, okay? Let's see. Oh, all right, Kendra. So, what is the fight versus flight response? Describe that for me.
That's your sympathetic versus your it's when you're either in rest and digest or you are like flight or flight, which means your everything constricts, your vasoconstriction, um, you have tachycardia, your heart's pumping, you have hypertension, everything's going faster in your body.
Okay. All right. Does anyone have anything to add to that? All right. So, a nurse is teaching a class about manifestations associated with flight versus flight response to stress. Which manifestations should the nurse include? So, would you see someone who's in fight versus flight response? Would you see a decrease in blood pressure?
No, it would be increase.
No. How about hypoglycemia?
It would be hyper.
It would be hyper. So we all know, remember, like stress does cause blood sugar to rise. So somebody who's had their blood sugar typically well controlled if they're going through something like a divorce or something like that, something that's very stressful, they could go to the clinic and their blood sugar could be elevated more than usual. Okay? Even though they've been taking the same dose of medication. What about bronchial airway constriction? Where do you see that?
No, it would open.
Okay. What about dilated pupils?
Yes.
Yes.
You would have dilated pupils. That is the correct answer. Okay. second here. Hmm. Okay. All right. So, what can we do, like nutrition-wise? What can we do to minimize stress? What do we want to promote for stress management?
Avoid alcohol, caffeine.
Okay. Is there anything that you can consume that can relieve stress or like relax the body?
Complex carbs.
So what?
Complex carbs.
Correct. Carbohydrates. So carbohydrates can help like stimulate more production of melatonin in your body. So that can achieve like a calming or a minimize stress. Okay. Going into sleep and sleep disorders. What are some manifestations that can happen due to lack of sleep? What can occur due to sleep deprivation?
Meaning like, sorry, what can cause sleep disorders?
Like someone who has like, say, I don't know, like I worked the past 2 nights and I was working tonight. I showed up tomorrow for like an 8 to 5 class. What would you expect my manifestations and my mood to be?
Like agitated, stressed.
Inability to focus.
Okay, very good. What else? Anything else? How about like depression, tension headaches,
Blurred vision.
blurred vision? How about altered taste? Can that have anything to do with sleep deprivation?
I don't think so.
No, no, that would probably just be COVID. But all right. What about sleep? What happens as a result of sleep? What goes on during sleep?
Your short-term memory turns into long-term memory.
Okay, very good. So remember that, okay? The short-term memory transitions into long-term memory. Okay. What constitutes sleep hygiene in the hospital? Like if you were teaching a new nurse about what sleep hygiene is, how would you explain it to them?
Basically, just creating some kind of nightly routine to get them in the mood to go to sleep.
Okay. What about like, would you go in there and flush the toilet or like, so basically you'd want to go in there and consolidate all your activities, right? You don't want to have to keep going back in and out, waking them up. One of the things is you can like minimize flushing the toilet during sleep hygiene unless you really had to. Okay. I know it's kind of hard in the hospital to minimize like the noise, but whatever we can do can possibly make a difference for a patient. What about sleep apnea? What are some things that you can expect to see with someone who has sleep apnea?
Headache.
Okay.
Obesity.
What else? I'm sorry?
Obesity.
Obesity. Okay. How about like something that's like a adverse effect or side, like something, a complication that can result due to
Stop breathing.
ap, sleep apnea?
Is it stop breathing?
Stop breathing. Okay. How
Snoring.
about like nausea? Can you have nausea with sleep apnea?
No.
No, no. How about headaches?
Yes.
So you could expect to see expect to see headaches in somebody who has sleep apnea. Okay. Moving on. All right. So going over pulmonary artery catheter. So why do we go ahead and put a pulmonary artery catheter in? What is the purpose of it?
Monitor the hemodynamics.
Okay, so hemodynamic monitoring, very good. Okay. All right. So when we're intubating a patient, then of course, hold on 1 second, guys. Sorry. So when we intubate a patient, how do we want to verify placement of the EP tube? How do you verify placement during intubation?
Gold standard would be like an X-ray,
Okay, an X-ray.
and then
But we can also do like assessing lung sounds, assessing symmetry, which whenever you have somebody who's intubated, you want to be able to assess their respirations in particular and also their lung sounds. If you see one side going like being higher than the other, maybe the ET tube migrated out of place. They'll have to get it. I mean, it's not definitive, but you're going to have to get an X. That's one of the things you would probably order an X-ray and get a better understanding what's going on. Why is the breathing asymmetrical? Okay. So make sure you guys know metabolic acidosis. Okay. Do you guys know what treatment you would give for someone who has metabolic acidosis?
Is it bicarbonate?
Yes, you're correct. So we're going to give bicarbonate, and you're going to basically have to monitor this, of course, their ABGs, and also possibly their electrolytes, like their potassium levels, because there may have been some fluid shifts. But you have to basically have a better understanding what's going on with the patient, of course. But definitely bicarbonate and monitoring your ABGs.
I'm sorry, you said acidosis, right?
Metabolic acidosis, yes.
Okay.
Now, complications of central venous access. So who could tell me what can go wrong when you're inserting or when a patient has a central line?
They can get an infection.
Infection, okay. Lupita, what would be another complication other than infection of insertion of a central line?
dysrhythmias.
Dysrhythmias, okay, very good. Michelle, can you name another one? Does anyone else know any other complications that can occur?
Hemorrhage,
The what?
bleeding hemorrhage.
Hemorrhage, yes, very good. What about a pulmonary embolism? Can that occur due to a central line insertion?
Maybe.
Yes, it can. Okay, so Most definitely, you can have a pulmonary embolism. So when you do have a pulmonary embolism, what kind of manifestations do you think you could see in someone who is having a pulmonary embolism?
Dyspnea.
Dyspnea, okay, shortness of breath, dyspnea, maybe tachycardia, they're anxious, okay? So if you're suspecting somebody has had a pulmonary embolism, what do you want to do? What is your first action?
Oxygen.
Well, first of all, you're going to clamp the catheter. So you're going to clamp the catheter, prevent any further like migration of the air embolus in the body. So you want to clamp the catheter, then you can apply oxygen for the patient. Okay. Do you guys know what position to put the patient in for somebody who has a pulmonary embolism?
Side lining.
So what?
You put them on their side.
Which side?
Left.
Very good. So left side, mainly because you do not want the embolism to move anywhere else. You want to trap the embolism right where it is. So you clamp the catheter, apply oxygen to lay them on their left side, and then you call the physician. Okay? Very good. All right, so cranial nerves. So what is cranial nerve 2? Can anybody tell me what is the cranial nerve 2?
Optic.
I'm sorry, what was that again?
Optic nerve.
Okay. And what about cranial nerve 3? What is that one?
Oculomotor.
Okay. So for cranial nerve 2, what are some tests that we can do to test the optic nerve?
Snellen test.
Snellen test. Very good. And what about for oculomotor nerve? What would you want to What would you want to assess?
Rilla. Accommodation.
Accommodation. Okay, so you want to check the pupil response to light. Okay. All right. So left versus right side. So in terms of brain function, remember the left side is the more logical side, right? It's logical, it's more rational, analytical, more objective thought process, whereas the right side of the brain is more creative and is more relational and more imaginative. Okay.
Hey, Professor, Chelsea's trying to get in.
Okay. Yeah. Okay. All right. So, if you have somebody who they come in with a severe headache, they say it's the worst headache of their life, what would you immediately think is going on with the patient?
Like maybe they have a stroke. I think they're bleeding.
Okay, so a hemorrhagic stroke, right? However, before we do anything else, we need to verify what kind of stroke it is. So the way you do that is through what?
CT scan.
CT scan. Very good. If you know you have a patient who has a stroke, say the patient's coming up in 20 minutes, you're getting the room ready, what would you need to do with the bed? What would you suspect the patient may need, and how would you prepare the room?
Seizure precautions.
Very good. Seizure precautions. So you would go ahead, if you have the time, go ahead and pad the bed rails, because pretty much stroke patients, like anyone with any brain injury, they probably may be at risk for having seizures. So you may want to implement seizure precautions, and the physician may also order anti-epileptic medications prophylactically. Okay. Now, for a hemorrhagic stroke, what do we want to maintain? What do we want to monitor?
Their blood pressure.
Very good. So we're going to monitor their blood pressure. Okay. You want to keep it within a certain range. I had a hemorrhagic stroke patient last night, and it was like keeping the blood pressure between 130 and 150. And then also monitoring PT-INR for any like issues with bleeding or coagulation. Okay. What is Cushing's triad? What does that consist of?
That hypertension, bradycardia, and like a wide impulse pressure and like irregular regular respirations.
They would have hypertension, bradycardia, and irregular respirations. Good job. Okay, and Janet, what does that indicate when someone has these signs? What are you immediately suspecting?
Swelling in the brain.
There's swelling in the brain, like the deterioration in neurostatus, increased possibly in ICP. So here's where you would want to do like immediate interventions, like maybe readjust the head of the bed, make sure it's 30 degrees, because that's the most optimal for drainage. You would call the physician and probably expect that you're going to be taking your patient for a CT scan, in addition to doing a like focused neuro assessment, trying to see like what's going on with the patient, what's changed, is there any changes neurologically, or like, yeah, if there's any like changes with your neuro assessment. In the meantime, also preparing the patient for a CT scan, because that's like probably the number one thing we can do to see if there's like a rupture and there's bleeding all of a sudden now. Yeah. Good job. Edgar, what is corticate posturing? What would that look like?
Kind of like when they're post-stable from a seizure.
Okay, so would the arms be flexed or extended?
Extended.
So with the corticate, the arms would be flexed, like inwards.
Got it.
So it would be flexed inwards. The cerebit would be flexed out, or not flexed, but extended outwards to the side. Okay. Does anybody know which one is worse?
The cerebit.
The cerebit. There you go. Good job. So not to say the corticate is bad, but the cerebit is just, it's a worsening, like, is a worsening of your neurostatus, of your, like, worsening, like, possibly herniation when you see the cerebit posturing. So if you see the corticate, the cerebit posturing, or Cushing's triad, what would you expect the doctor to order in terms of treatment? So what are some interventions that we can do?
Mannitol.
So we can give mannitol, very good. So you can give mannitol. What else? So you can give mannitol.
Is it albumin?
Not necessarily albumin, but you can give 3% saline. Okay, so 3% to kind of draw out some of the excess fluid. Some physicians like to give corticosteroid medications. I know there's like a lot of research that's going into that. Some say it's positive, some say it doesn't really do anything. We can go ahead and put a drain in to drain out some of the fluids, or they can take the patient to surgery and do like a shunt to shunt the fluid away to try to maintain the equilibrium in the brain, in the skull, so it's not causing any herniation. Okay. So subdural hematoma. So, Chelsea, what is a subdural hematoma?
It's like when you have basically like a brain bleed.
Okay, so kind of like a brain bleed. Okay, it's more like, I don't know, it's kind of like a clot, kind of. So they're going to go in surgically. Usually they'll surgically do a hemicrania or craniotomy or craniectomy and remove that portion, that clot, or where the hematoma is, evacuate the hematoma. So, once you have a patient who is like status post, say they had a clot evacuation, what is the priority in terms of like our assessment? What are we prioritizing? Number one,
O2 and respirations.
respirations. Okay, so you want to make sure the oxygen saturation is optimal. You apply oxygen on the patient. It's not necessarily doing neuro first. It's going to be your airway, breathing, circulation. Okay. All right. Who can tell me about bacterial meningitis? First of all, what kind of precaution is this?
Droplet.
Droplet precaution. Okay. So just remember, if we have a patient and we're suspecting bacterial meningitis, the first thing would be isolation. So you isolate that patient, protect ourselves, protect everybody else. Okay. After that, what is our next priority?
Get the cultures.
Good. We'll do cultures. Okay. So we'll do cultures, and then once we draw the culture, then we can give broad spectrum antibiotics until we can narrow it down and get the results back. Okay. But basically, it's going to be isolate the patient, draw blood cultures, antibiotics, and fluids. In terms of monitoring, you want to, of course, monitor the WBCs because that would basically identify like if the body's like how the infection is the infection improving or is it getting worse? And you're also going to monitor level of consciousness because that can also identify like how the treatment is progressing. Okay, is the patient's orientation getting better or getting worse? Is the patient becoming more confused? Okay, so those are some things you want to keep in mind in terms of bacterial meningitis. All right, so we briefly went over hemorrhagic stroke. So just remember that classic sign for that is the worst headache of their entire lives. So that one should be a huge red flag for a hemorrhagic stroke. Like if someone, like if you're like with your kids at the soccer game and somebody there saying they have the worst headache of their life, you should probably call 911 and get that patient to the hospital like immediately. What is homonymous humanopsia? What is that?
You lose eyesight in one eye.
So basically you have a vision field, like a visual field deficit. So it depends on whatever side the stroke is on, okay? But say like I have a right field deficit. So that means in both my eyes, I can only see on the left side. So what would you want to teach your patient?
Scan the room.
To scan the room, very good. Scan the room, tell them, because patients who have a stroke may experience, like, say if I had a left-sided stroke, I may have right-sided neglect. So I'm neglecting my whole right side. So that is a problem when you have things like, I don't know, like I'm not aware I have my right arm here, and maybe like, I don't know, it's like hanging out of the bed and like they're going to CT and it keeps banging into the wall or something like that. The patient probably won't be able to feel that. So you have to really make sure they are aware that they have their right arm there. Okay, so we could probably put it in a sling or something to make sure they always look at their arm and make sure they know it's there, because a lot of them may not realize that they have a right arm there because they can't really feel it. So you want to teach them to scan the room, put key items within their view on their like left or right side where the deficit is. What are some other complications that can occur as a result of a stroke?
Other like, I don't know, like one-sided weakness.
Okay, weakness on a certain side. All right. Jessica, can you identify like another complication that can result from a stroke, or something that we need to intervene with someone who has a stroke?
Peas.
PEs. Okay. So the patient may not be able to move around in the bed as like somebody else would, so they probably be getting risk for blood clots. Okay, they would also have risk for skin integrity and also possibly dysphagia too. Does anybody know like how to educate them if they're able to swallow, like how we want them to like swallow their food?
Chin to chest.
Their chin to chest.
Yes, so have them tuck their chin to their chest when they're swallowing, and then also remove any like distractions during mealtime. So preferably not want them to watch TV or anything. And if we really need to, we can institute like enteral feeding or even TPN as well. Okay, so all those can be due to a stroke because they're not able to really, depending on the stroke, not really able to do their activities of daily living themselves. Okay. All right, Zai, what is dementia and delirium? What is the difference between the two?
One is progressive dementia, and then one is onset, and it could be reverse delirium.
Okay, so delirium, which one is has a shorter onset, delirium or dementia?
Delirium.
Delirium, very good. So when you're determining is this delirium or is a patient has dementia, you want to look at how did the patient come in? If the patient was oriented on admission 3 days later after surgery, the patient comes back and he's like climbing out of the bed. It's not dementia, it's probably delirium. And we have delirium screening protocols for this and certain treatment options such as like decreasing stimuli. We can put them close to the nurse's station. We can utilize things like bed alarms. We can use Haldol or Precedex. Okay, there's a lot we can do to help manage the delirium. Okay, so all right. So a nurse is caring for a client who has a spinal cord injury at the level of the T2 to T3 vertebrae. When planning care, the nurse should anticipate which of the following types of disability. So if someone has a T2 to T3 vertebrae injury, would you expect the patient to be quadriplegic, hemiplegia, paresthesia, or paraplegia?
Paraplegia.
So paraplegia, why is that?
Because they're paralyzed from the waist down.
Okay, very good. So they would still be able to utilize their arms and basically do like all upper extremity, like upper body functions, right? It's just their lower extremities, they probably won't be able, they will be paralyzed from the waist down, correct? Okay. A home health nurse is caring for a patient who is a quadriplegic following spinal cord injury. He is adjusting to the home environment. Which of the following client statements indicates the client is adapting? So my wife tries to get me to go to the grocery store. However, I don't like to go out much. I am using the modified feeding utensils at every meal. I still spill, but I'm getting better. My greatest pleasure each day is having a few beers every day, or I have all the equipment to take a shower. However, I prefer a bed bath because it is easier. What do you guys think?
I still spill, but I'm getting better.
Correct. So still spill, but I'm getting better because it's harder for him to utilize the modified utensils. However, he's adapting to it. He's still getting used to it, but it's getting better. Whereas the other one's like he has all the equipment for the shower. However, it's easier for him to take a bath. And then you should never never relate to like alcohol. So my greatest pleasure each day is having a few beers every day. And then also the other one, my wife tries to get me to go to the store, but I don't like to go out much. Okay, so the best option here is utilizing their modified feeding utensils. All right, so you can tell me what are some manifestations of autonomic dysreflexia?
Sweating.
I'm sorry?
Diaphoresis. I think that's like when everything just goes up, like your blood pressure, your sweating.
Yes. So if you have someone who reports they have a spinal cord injury and they have severe headache, blood pressure is 210/108, your suspicion is probably that the patient is having autonomic dysreflexia. So what is your first course of action?
Repositioning them, setting them up.
Right. So the best position would be placing them in a high Fowler's position. Because typically when they have autonomic dysreflexia, that's usually because of like some sort of stimulus, such as like maybe their bladder is over distended and they need to void. Okay. Sitting them upright can relieve some of the pressure there and hopefully cause their blood pressure and their heart rate to stabilize momentarily, while you can go and assess and see what's the triggering cause for this, what's causing the autonomic dysreflexia. And at some point, it might be the bladder. Just palpate, oh, the bladder's distended, let's put a straight cast and see how much is in there. Okay? Okay. So, in preventing autonomic hyperreflexia, so which action will the home health nurse include in the plan of care for a patient who has paraplegia and is paraplegia at the T4 level? Support selection of a high protein diet, discuss options for sexuality and fertility, assist in planning a prescribed bowel regimen, or utilizing a quad coughing to strengthen coughing efforts. What do you think would help prevent autonomic hyperreflexia?
Bowel, right? Like the bowel regimen?
The bowel regimen, correct. Okay. So a lot of patients probably won't be able to sense when they need to go to the restroom or to defecate. So we might have to have a routine where they go and like establish a routine when they're supposed to go and evacuate their bowels. Okay, so it doesn't build up and cause stressors causing autonomic hyperreflexia. Okay, so you want to establish a bowel training regimen for them. All right. So who can tell me what is trigeminal neuralgia?
Sudden severe facial pain.
I'm sorry, can you say that again, please?
Severe facial pain.
Okay, facial pain. Okay. So what would be some nursing interventions for this?
Would it be like avoid touching their face?
Okay. And then I had one here. I'm trying to see where it is in the exam here.
Assess their intake.
Assess their intake. Okay. Good job. Oh, yeah, here we go. So, which action will the nurse include in the plan of care for someone experiencing pain from trigeminal neuralgia? You want to assess their fluid and their dietary intake. Okay, assess their nutritional intake because this may be something that may be preventing them from adequately achieving their optimal nutrients. So you want to always assess that. Okay. All right. So. All right. So you have a patient who has alternating periods of hyperventilation and apnea. So what would you classify this as? You have a lot of hyperventilation and mixed with periods of apnea. So what kind of breathing? This is a type of breathing. What kind of breathing is it? What would you document it as?
Cheyne-Stokes. I always say it wrong.
You're correct. So Cheyne-Stokes. Okay, good job. So Cheyne-Stokes respirations. Okay. All right. So what is our priorities? Like, what is our top 3 priorities for pulmonary edema? So someone comes in, we suspect they have pulmonary edema. What would be our top 3 priorities for them? Oh, I'm sorry, top 2. So number 1 would be oxygen. Okay, so definitely you want to apply oxygen for the patient if you notice they start to desaturate. And then after that, you call the physician, then we can get something like heparin or some kind of like blood thinner. Okay. And then of course you're gonna have to monitor PTT levels as well. So oxygen and then blood thinner or like heparin. So with ARDS, so what is going on with ARDS?
They're like breathing ineffectively.
Okay. Michelle, can you tell me why, like, what we would do for someone who is an ARDS? What position is best for them?
Face down.
So prone. So
Yeah,
prone position,
prone.
very good. So you would have to prone, likely we'll have to prone them, okay? Typically with someone who has ARDS, these patients probably will get intubated and they have to be sedated, and I don't think I've ever had a patient who's been prone without being on paralytics, but So I think you have to be on paralytics first, and then proning is the last step. Like if all else fails, that's the last step that we do. And after that, that's basically all you can do. So the problem with ARDS is your lungs are so stiff, it's like difficult to like ventilate, difficult to expand effectively to maintain adequate oxygenation. So that's the problem. And because of ARDS, a lot of the physicians try to increase like the PEEP, to try to add a little extra pressure in the lungs to keep it open. However, with so much PEEP, you can have a rupture. You can rupture the lungs and cause like a pneumothorax or barotrauma or some other complications. So that just makes it like a whole lot. It just makes it so much worse. So yeah, so we'll put them in prone position. That is typically the best position for someone with ARDS. All right, so dysrhythmias. So when we have patients with dysrhythmias, one of the medications we can give is verapamil. Okay. Does anyone know? Hold on a second. I'll get back to it when I see it in here. All right, so for dysrhythmias, make sure you guys know there's going to be a few dysrhythmias on here. Atrial flutter, second degree block type 2. Okay, I'll give you a hint that it's going to be a bow tie question. So make sure you know what interventions to do and what parameters to monitor for second degree block type 2. You'll also need to know pulseless ventricular tachycardia, and then also first degree block. And then also know there's one pacemaker rhythm failure to capture. Okay, so know failure to capture and be able to identify like what it looks like on the monitor and when you would what you would do to like call when you would call the physician. Okay. All right, so on your test, there is kind of a bit of select all the apply questions. One of them here is a nurse is in the ER monitoring a patient who has a cervical spinal cord injury related to a fall. The nurse should monitor the patient for the following complications. Okay, so he has a cervical spinal cord injury due to a fall, and you're monitoring for what complications? So hypotension, polyuria, hyperthermia, absent bowel sounds, or weakened gag reflex. What would you monitor for? What complication?
So that wasn't a select all that right? That wasn't a select all that apply?
That is.
Oh.
So there's 3 answers in there. Okay.
Can you repeat that?
Weakened gag reflex?
So weakened gag reflex. Okay, so that's one of them. Okay. What else?
Was it sorry, can you repeat the other options?
So hypotension, polyuria, hyperthermia, absent bowel sounds, or weakened gag reflex.
The last 3, weakened gag reflex, the absent bowel sounds, and the hyperthermia?
So it would be weakened gag reflex, absent bowel sounds, and then hypotension.
Oh.
Okay. So hypotension. All right. So if you have a patient who they have a rhythm and it looks like it's failure to capture on the monitor. Okay. What does that mean? Failure to capture.
Like something's not connected right, where the monitor is not assessing the body correctly.
Okay. And what would you do in that point when it's a failure to capture? What do you think would be an intervention?
All the providers.
I'm sorry. Now it looks on here. I'm looking at it on here. It looks like to me it's failure to pace. So if it's failure to pace, it means failure to pace. You have your pace. You have your rhythm, right? So when there should be a pace, there's like no P wave, no QRS. There should be a pace there to initiate the P wave, but there is none. So it's basically just like a period where it's just nothing there, no rhythm. So at that point, you would want to do transcutaneous pacing in a patient like that, okay? Because you need to be able to like effectively determine when it needs to be paced, okay? If you have failure to pace, there are certain areas that the pacemaker, for whatever reason, is not pacing on that when it should be. Failure to capture, on the other hand, means that there's a pacing spike, but there is no capture of that pacing spike. So there's a pacing spike, but no P wave, no QRS. Okay.
Wait, Mr. Wilson, I have a question. Sorry.
Yes.
You said failure to capture is different than failure to pacing. And you said for failure to pacing, the P waves and QRS doesn't show?
So why do we need to pace? Because there is no waveform, right?
Yeah.
We need something to initiate the electrical charge.
Mm-hmm.
So typically, like, depending on the pacemaker, if it's like atrial pace, you'd have a pace spike, and then you would have the P wave. And then if it's ventricular pacing spike, QRS.
Okay.
So failure to pace basically is there is no QRS. Like say for atrial pace, okay? If it's atrial pace, there's no P wave. There should be a pacing spike there to initiate that P wave, or for whatever reason, pacemaker is not firing on that spot.
Oh, okay.
So that's what it is, like failure to pace. It's not pacing it as it should be. Failure to capture means that there is a pacing spike where it should be, right where it should be, but there's no P wave afterwards. There's no response.
Oh, okay.
That is failure to capture. So failure to capture that electrical charge from the pacemaker.
Okay, that makes sense. Thank you.
Mm-hmm.
I'm sorry, I have a question about that. So basically, like the failure to pace, there's no spike, and then failure to capture, there's a spike but no QRS following it, or P wave.
Yes, depending on what type of pacemaker you have. Yes.
Okay, thank you.
All right. All right. So there'll be times that you're going to be assisting the physician with certain tests, like maybe inserting a central line, inserting a cardiac catheter, or doing cardiac catheterization. Which of the following actions should the nurse take? Okay, so this is basically like a select all the apply. However, it is an NGN question, so basically you do get partial credit for this one. So, as a nurse, are we going to be filling out the consent for the procedure?
No.
No. What is our role in terms of consents?
Just verify that they're consenting.
We're supposed to be a witness for the consent. So we just witness that the patient understands what the procedure is and that the doctor has explained it to the patient. Okay. Sometimes, like when I have a patient that's the doctor is giving him consent for a blood transfusion, when I witness them, I ask the patient, okay, so like tell me what you understand from the, like what do you understand about the procedure you're about to have or about receiving a blood transfusion, and I make sure that they adequately are knowledgeable about the procedure or what the risks and benefits are. So basically, you're basically just witnessing that consent was given by the patient and they're properly informed. You would also obtain vital signs, okay, pre-procedure vital signs, maybe intra-procedure, like during the procedure. So if the doctor, when I used to do like ventriculostomies, like the doctor used to do ventriculostomies, I would assist the physician and I would basically be in charge of making sure the patient was adequately sedated. So I'd be looking at the patient, making sure his breathing is optimal, but he's not like grimacing, he's not moving around, his vital signs are stable, he's not hypotensive, okay? And then lastly, confirming allergies, okay? So as a nurse, you have to go through the patient history and know about the patient, know like what allergies the patient has, and if it's a contraindication for whatever procedure. So maybe if they have allergies to eggs or something like that, it's possible they may have a reaction to contrast. So you need to know that. All right, how often are we giving taking nitroglycerin?
Every 5 minutes or 3 times.
Every 5 minutes. Okay, very good. All right. So, have you guys seen TPA given before?
No.
No. Well, so TPA typically is in it's one of those, it's in a vial, it's a powdered form. So you typically have to reconstitute it with some fluids, okay? So typically you want to administer the medication within 30 minutes of arrival to the emergency room. You want to reconstitute the medication with sterile water. You want to administer it you want to administer 15 milligrams bolus and then assess for any back pain. So with TPA, it's typically given there's a bolus dose and then you have a continuous infusion like for a period of time. Okay, so typically you basically reconstitute it, administer the bolus, administer the maintenance infusion, and then you're going to assess for any back pain. Why do we assess for back pain? What might that be indicative of?
Your kidneys?
Kidneys. So it would be indicative of retroperitoneal bleeding. Okay, so you want to make sure like any back pain, but also their neurostatus too. If they start having alterations in neurostatus, maybe there's maybe they're getting I don't know, like a ruptured aneurysm or something like that, or there's like increases in ICP. So you want to make sure you're assessing not only their neurostatus but also like for back pain. So back pain typically is due to the possibility of retroperitoneal bleeding, which can occur. So patients who present with any kind of chest pain, what do you expect the physician to order? Let's talk about diagnostics first. So what diagnostic tests are we going to see?
EKG.
12-lead EKG, okay. And then what else?
Troponin levels.
Cardiac biomarkers.
Cardiac biomarkers, specifically troponin. Okay, so troponin and 12-lead-EKG. So the patient doesn't necessarily have an MI, but say their troponins are elevated. We're suspecting maybe it's like angina. So what is the treatment option? What are we going to treat with? I'll give you a hint. We give it 3 times every 5 minutes.
Nitro.
Nitroglycerin. Very good. So nitroglycerin, for someone who has an MI, we can give morphine, oxygen, nitroglycerin, acetaminophen. Okay? But no matter if it's in the field or wherever you are, if the patient has chest pain, it's always beneficial to give them an aspirin. Okay? So aspirin, no matter if they've had like an EKG done or troponins done, or if you're in the field and you don't have any of that on access, just give them an aspirin and wait for the paramedics. All right, so someone who's scheduled for a cardiac catheterization, which of the following medications taken by the patient would interact with contrast materials and be at risk for AKI, acute kidney injury? So atorvastatin, metformin, nitroglycerin, or carvedilol?
Metformin.
Metformin. So you want to make sure if the patient is taking metformin, you need to know that, because that can interact with the contrast and cause issues with your kidney function. Okay. So you're a post-op nurse. You're recovering a patient who had a cardiac catheterization. What is the best position to put the patient in?
Supine.
Supine. Very good. So you keep supine. You know why we keep them supine?
To reduce the risk of bleeding?
Okay, so you're right. Reduce the risk of bleeding. So you want whatever site they use. Typically, they use the femoral, so that's one of like the bigger veins. So you typically use the femoral vein. So you want to keep that leg straight for like 4 hours. So no bending, no nothing. If they're short of breath, what you can do is keep them straight, but elevate just like the whole bed, like tilt it forward so their head is upwards. Okay, now don't tilt it all the way that they slide out of the bed, but just barely enough just to keep the head a little elevated. But you want to keep that leg nice and straight to minimize risk for bleeding, for hematoma. Okay, and then also you're checking your pulses and vital signs as well. All right, so if you have a patient who developed heart failure due to an MI, would you question the doctor when he puts an order in for normal saline at 50 milliliters an hour?
Yes.
Yes.
Why is that? Why would you question that order?
You're at risk for putting them in fluid overload.
Okay, very good. So the patient does not need that extra fluid. Okay, so 50 milliliters an hour, that doesn't seem a lot compared to like, I don't know, like 120 or 125 that some other patients may be on, but that's still extra fluid that's going in there, and that can worsen the heart failure because of like congestion. So when someone has congestive heart failure, typically we're going to try to get rid of fluid, right? We're trying to like give Lasix to get that fluid out. Okay. In addition to like with Lasix, what is the side effect that we have to watch out for?
Hypokalemia.
Hypokalemia. Good job. So hypokalemia. All right, so what is the difference? So Edgar, what is the difference between left-sided and right-sided heart failure?
You're talking about like the signs and symptoms?
Okay, so what would left-sided heart failure be?
Well, you have like agitation, pulmonary congestion, crackles, restlessness, trouble breathing.
Okay, very good. Louisa, what about right-sided heart failure? What would you have with right-sided heart failure?
Edema, extended jugular veins, fatigue.
Okay, very good. So definitely a lot more systemic effects like this jugular vein distension, edema. Okay, very good. What would be some signs of fluid volume? What would be some signs of fluid volume overload in a patient? Say a patient's getting, they're getting a blood transfusion, and you're monitoring for fluid volume overload. So, what signs would be looking for?
Process,
Okay. What else?
pulmonary congestion, restlessness.
Okay. So, jugular vein distension, confusion, shortness of breath. Okay. Not necessarily hypotension or GI bleeding, GI gastrointestinal bloating. All right. All right. Let's see. So, Deborah. So, someone who has right-sided heart failure. Do you know what kind of findings would be expected in terms of hemodynamic? What would be elevated?
Increase your urine specific gravity and elevated CVP.
Okay. But what kind of like hemodynamic, like pressure? Oh, okay. I'll give you two of them. So it's either central venous pressure or pulmonary artery wedge pressure. What do you think would be increased?
Central venous pressure.
Very good. So central venous pressure. Okay. The right side of the heart supplies the system, body system. So you would expect a rise in elevation in your central venous pressure. Very good. All right. So moving on. All right, infective endocarditis. Okay. So what is the priority when you have a patient coming in with infective endocarditis? What are we prioritizing as number one that we have to focus on first and foremost?
Dyspnea?
I'm sorry, what was that?
Shortness of breath?
Shortness of breath? Not necessarily. So, infective endocarditis. So, what is the one of the things that we want to do primarily when the patient comes in? We need to get
cultures.
blood cultures. So you want to get the patient started on blood cultures and get the antibiotics going as quickly as possible. Okay. So you want to educate them when they're discharged home. They may be needing antibiotics at home. So they may go home with a PICC line and need continuous periodic infusion of antibiotics. You want to have them take the whole dose. Don't stop the antibiotics, okay, until you complete the dose. So you never want to stop, any medication, just like that. You don't want to continue the whole dose. And then if you're going to have any dental procedures, you want to inform whoever is doing your dental work that you had infective endocarditis, right? Because possibly they may need to give you some prophylactic antibiotics prior to the procedure. So. All right, so a patient has acute pericarditis. The nurse has identified a nursing diagnosis of acute pain related to inflammation for someone with acute pericarditis. What is an appropriate intervention by the nurse for this problem? So how are we going to help manage the acute pain related to pericarditis? So is it A, teach the patient to take a deep breath, to take deep, slow breaths to control the pain? B, force fluids to 3 liters per day to decrease fever and inflammation? C, provide fresh ice bag every hour for the patient to place on his chest? Or D, place the patient in a Fowler's position leaning forward on the overhead table?
I'm gonna say D.
It is correct. So it is D. Okay, so you want to have the patient lean over in a Fowler's position, leaning over the overhead table. It's kind of like tripod positioning for someone who has COPD. Okay. All right, so someone who has pericarditis, so make sure you guys know what nursing interventions. Specifically, there's one that's going to be for treatment, and then the other is for diagnostics, and then what parameters to monitor for. Okay, so make sure you guys know that. That's going to be a bow tie question, pericarditis.
Sorry, and then you said for the one before that, you said that acute endocarditis, and that's when they lean forward, right?
Pericarditis.
Pericarditis, sorry.
Mm-hmm. Yeah, so place the patient in a Fowler position, lean forward over the overhead table. That's to help manage your pain.
Mm.
Okay. So rheumatic fever. So what is the major cause of rheumatic fever? What does it typically follow? What kind of infection?
Strep throat.
Streptococcus. Okay, very good. So streptococcal infection. So if someone comes in with suspected rheumatic fever, one of the assessment questions would be, have you had a sore throat recently? Or has your son had a sore throat recently? Okay. So you want to assess for any recent streptococcal infections. In terms of community health, okay, you want to teach community members to seek treatment for streptococcal pharyngitis, okay? So when developing a community health program to decrease the incidence of rheumatic fever, which actions should the community health nurse include? It would be teaching community members to seek treatment for streptococcal pharyngitis. Sylvia, so someone who has mitral valve stenosis, what finding would you expect to see on the patient when you're doing your assessment?
It's gonna be like, I don't know, like shortness of breath, a murmur,
Murmur. There you go. So heart murmur. Okay. So you expect to hear a heart murmur on a patient who has mitral valve stenosis. So know that lifelong anticoagulant therapy is needed for those who have mechanical valve replacement. Okay. So those with mechanical valve replacement will need lifelong anticoagulation. And then also for those who have mitral valve replacement with a mechanical valve, again, just like infective endocarditis, they need to let their dentist know before going through any dental procedures. Okay, so they may need some prophylactic antibiotics prior to the procedure. Okay, Kimberly. So the nurse is caring for a 64-year-old patient admitted with a mitral valve regurgitation. Which of the following information obtained by the nurse when assessing the patient should be communicated to the healthcare provider immediately? Option 1 is the patient has 4+ peripheral edema. B, the patient has diffuse bilateral crackles. C, the patient has loud systolic murmur across the pericardium. Or D, the patient has palpable thrill felt over the left anterior chest.
I'm gonna go ahead and say D.
B. That's very good. So it is B. So you have mitral valve regurgitation. So you have like a backflow of fluid, and it's flowing back and affecting, like going into the lung circulation. So it's causing deep bilateral crackles. So here's where you'll have your airway breathing circulation assessment. So you need to highlight that as a priority when you have bilateral crackles, because it's starting to affect your breathing. Good job. All right, so what are some signs of shock? Like, just looking at the vital signs. The heart rate, what would we see, like, in terms of shock? Someone who's undergoing, currently in the state of shock. Would they be tachycardic? Would they be bradycardic? What would they be? So yes, it would be tachycardic. Okay, so maybe someone who has possible shock, you could probably, from a surgery, they could probably see the heart rate go from 88 to immediately to 110 as the body's trying to compensate. Remember that respirations are probably the earliest identifier that a shock, like there's a impending like shock that is coming. So that's one of the earliest signs of shock, the respirations, tachypnea.